Our clinic's been in existence here for nearly 20 years, and what we're going to be talking about is the non-surgical solutions to knee pain. So I'm assuming, typically, if you're watching this on video or live on Facebook, or you're here, you're at this lecture either because you just want to learn about it because it seems like a fascinating subject, or in most cases you or a loved one are actually having knee pain and you're hoping you might find a solution that you haven't tried yet. So does each of you that are here in the room actually have knee pain? All of you? Okay. All right, so we'll start talking about some of these solutions. Let me just kind of ask a question. What have you tried? What have you guys tried so far? Have you had a diagnosis, and what have you tried so far?
Cortisone shots.
Cortisone shots? Cortisone.
I hadn't had any diagnosis, but I've tried turmeric. That has helped.
Okay.
I've got insoles from Dr. Holt. That has helped.
Okay.
And one thing that's helped is wild to me, I started instead of slip-on, getting an 8-inch lace-up.
Uh-huh.
And that made a big difference.
Made a difference.
No, nothing's cured.
Okay. But all these things have helped.
And another thing is laying off sugar.
Yes.
That's like this week I've had, like last night I had a honey bun.
And you felt it today?
Well, there's one Sunday I done, the week before I done real good. One Sunday, I ate 2 bowls of banana pudding and a piece of key lime pie. That was on Sunday night. It was Thursday. I mean, I'm going to say within 4 hours, my joints was hurting, my stomach was hurting. Within 4 hours,
Yeah.
I'm hurt.
Yeah. So it's great. This is why I had the dialogue. So he really started to talk about some other concepts, and there's actually a diet that's called a deflating diet. Okay, so he hit the nail on the head. Sugar and refined carbohydrates, meaning our breads and our pastas and those types of things, will cause an inflammatory response in the body. And if we have a condition like osteoarthritis, which is what most people who come to see us with knee pain have, osteoarthritis, which is simply wear and tear of the joint over time. Okay, there can be biomechanical issues. You mentioned orthotics, so that is one thing that we advocate. Is we actually have an ability to look at someone's foot stance and gait and determine whether or not their feet are rolling in or out by typical watching gait patterns, whether their foot turns in or out, whether by x-rays you can see whether their knee is actually tracking correctly. So there can be biomechanical issues that are causing, oh yes, I'm sorry, you're right, part of knee pain.
Thank you.
And so there can be biomechanical issues that are causing part of knee pain, and those things need to be addressed. Sometimes our low back can have an issue, and the nerves that come from the low back can travel down into the legs and can be part of the knee pain problem. And that can be a reverse relationship there too. Obviously, if you walk and your gait is not normal, or you have a limp because you have knee pain, that can translate into a low back problem, which then feeds back into the knee problem. So you can start these vicious cycles that if you don't address each thing as its own thing, then the person never gets complete recovery. Some of the other solutions that you guys might have, may or may have not tried, besides the cortisone injections, has anybody tried prescription or over-the-counter medication? You mentioned turmeric, which is an herb that decreases inflammation, works very well, and actually there's been clinical studies done that showed that 750 milligrams of turmeric over a 60-day period of time outperformed meloxicam. Okay.
Another thing, you got to have black pepper for the turmeric work.
The formulation of how it absorbs in the body is important. And that's the other thing, is making sure that you're getting a good nutraceutical. Unfortunately, most of the companies that, in the supplement industry, it's not regulated by the FDA. And so there are only a couple dozen companies that actually do what we call individual assays, where they actually test what's on the label is what's actually in the bottle. And unfortunately, when you go around, about 80% of everything on the marketplace, if we took it off of the shelf and we looked at it and said you had 500 milligrams of X, and we tested, and does not have 500 milligrams of X, and sometimes it has as low as 1 to 2 milligrams. Sometimes it's a big difference. So the quality of what you buy in those things can make a big difference. And knowing what companies do those assays and actually regulate that like a pharmaceutical company would, you're going to get a higher quality product. You're usually going to pay a higher a higher price for that too. So we use a company that does that. It's called Designs for Health. It's on our website at advancedrehabjackson.com. There's a little in the top right-hand corner it says Designs for Health, and it's an online store, and obviously we carry that stuff here quite a bit too. How many of you have tried prescription medication? What did you try?
I'm right now taking Lorstan and EEF. It's not going to roll down the middle.
Okay. And what about yourself?
Meloxicam, and ibuprofen 800.
Mm-hmm. Okay. Is that something, ibuprofen, you take every day?
No.
Okay. That's good. Because the meloxicam is actually easier on your kidneys and your digestive tract. We have to be careful about taking non-steroidal anti-inflammatories. How many of you know what a non-steroidal anti-inflammatory is? No?
I know.
Okay. So a non-steroidal anti-inflammatory is like our ibuprofen, our Advil, our Aleve. Those are what we consider non-steroidal anti-inflammatories. In taking, research has shown taking in dosages on a regular basis over a long period of time will cause kidney issues and digestive issues. As a matter of fact, let's see, I don't have those statistics up here, but it's believed. You remember what that statistic is, Christy? We used to have it on the old PowerPoint, but the number was significant. It was thousands of people every year die, and it was a couple, tens of thousands,
right.
That die every year taking too many NSAIDs because it causes gastric bleeding and problems with your kidneys and liver. So if that's something, sometimes I'll get people in and say, yeah, I just take a couple of ibuprofen a day. And I'll be like, a couple a day? Yeah. Oh, how long have you been doing that? 6 months. You start thinking about it, okay, there's 365 days in a year. If you've been doing that for 180 of those days, you took 2 a day, you've taken 360 ibuprofen over the last 6 months. That might be a problem. Okay, so
That hard to deliver.
yes. So taking that stuff long term is not it may help you feel better, but you need to be searching for a more permanent solution because those things have side effects. Meloxicam is a little easier on us than taking even the over-the-counter. You would think that because it's prescription, but that is the case. You really want to stay away from those NSAIDs. You would be better off trying to use some natural things like turmeric, like glucosamine chondroitin, like MSM, all of those things that can help to lower the inflammatory response of the body, but not have the side effects. We use something that's called a medical food. That so you kind of got supplements here, and then medical food here, and then prescription drug here. Supplements you can get just about anywhere, but you got to get high quality. A medical food you actually have to have. You'll have to get in a physician's office, like our office. You cannot go to a supplement store and buy it, but you don't have to have a medical prescription for it. Does that make sense? Okay, but it's not sold to the general public. So one of the ones that we use is medical food. It's called Arthrobin, and it has the same mechanism as a COX-2 inhibitor, which is how Vioxx and Celebrex. Welcome. Vioxx and Celebrex actually work. You guys remember Vioxx and Celebrex? Okay, they're not on the marketplace because of long-term research showed cardiovascular injury that was caused by that. So this works in the same mechanism, but it's all natural with not the side effects.
You don't sell Celebrex anymore?
What's that?
You can't get Celebrex?
I know Vioxx is not on the marketplace anymore, and
I was going to say, I used to take it.
Is Celebrex still?
Sometimes it's still giving.
It's not giving out very much because of, it's got some of the similar side effects that we see with Vioxx. So any prescription medication like that has an anti-inflammatory, most of them, do have some side effects that are associated. Some of them have been found quite severe. That's why they pull Vioxx off the marketplace. The Arthrobin, and being a medical food, works to a similar degree, without all the side effects. Okay, the problem for some is that it's not covered by your major medical insurance, and so then there might be an out-of-pocket expense, and that's why you don't see it as much. But overall, it's a better product with the same results with less side effects. Okay, we're going to get into that's kind of the biochemical side of things. Certainly, people when they're in a great deal of pain, besides these anti-inflammatories with slower inflammation, but then in the past, not as much now, you had people that were getting pain medication, okay, like opioids. Of course, everybody knows about what that looks like in our area and other areas now because of the high addiction rates. So you won't see too many physicians unless you're stuck into a pain management clinic because you have failed all conservative options. Then you might be on long-term prescription opioid medication for a problem. But otherwise, you will not be able to get it at just a walk-in clinic or a primary care clinic.
Right. If
you get it, it won't be for a long period of time, a week or two, maybe 30 days tops. Okay. So then the other thing that typically comes, how many of you have tried any type of therapy, like physical therapy? Okay, tried physical therapy for your knee pain? Anybody else?
Well, yes, I've been to Opioid therapy,
Yes, that's physical therapy. Okay. Because typically, like the hierarchy, if you go to your regular doctor, your medical doctor, who's your primary care physician, they're going to evaluate you. If it's arthritis, they're going to give you a diagnosis, maybe try you on some prescription medication like a meloxicam, then maybe send you to physical therapy next, or maybe a cortisone injection next, and then what is it that you're told after that?
You need a knee replacement.
You need a knee replacement, right? Okay, that's what, if you failed all of those things, that's generally what's next. Now, most of the people that come to our lectures are here because they've been told that, and they don't necessarily want to do that. Why would we not want to do that?
I'm tired of operating.
Tired of operations. Okay, any other reasons?
Well, if I had a knee replacement, that's what I was telling the doctor, if I got a knee replacement, I had to get 2 knee replacements, I had to get a back replacement, I had to get a lot of shoulder replacement, so I would have to have, in order to, to fix one, I think I'd had to get all 3 of them.
Yeah, that's kind of not realistic to be able to do, especially not all at once.
Yes.
And the fact is, for knee surgery, a total knee replacement, unfortunately, even in modern medicine, and I think, we kind of, with the coronavirus now, we kind of see that. It's like modern medicine doesn't have a solution for everything. So even with the knee replacement, the Journal of Orthopedic Medicine says that, we've got about a 50% success rate. Okay?
For knee replacement?
For knee replacements.
Wow. That's terrible.
Yes, I know.
They told me to lose 50 pounds.
Told you to lose 50
I
pounds.
said, what? That'd be less than I weighed in high school.
So the scary part about that is the surgery is not an easy one. The recovery is not an easy one. And the fact that even if it goes well, we've got a 50% chance of getting better. Now, who likes those odds? Now, who likes those odds if I told you that the average knee replacement is about $55,000? I don't know about you. Now, granted, that would be if you have insurance. Your insurance might be paying the majority of that. But even if you have an 80-20, your 20% of $55,000 is a pretty good chunk of change. That's about 10 grand. Okay? So, to me, for $55,000, I think we ought to have better odds than a 50% success rate, but that's what the Journal of Orthopedic Medicine says. In addition to that, the average life of a knee replacement is about 9 to 10 years. Okay? I said average. I'm not saying there won't be people that last 24, but the average is about 9 to 10 years. So then that's the other thing. It's like when we're looking at a knee replacement, what's your age? Because if you do it too young, you might have to do it again. Okay? If we wait too long, some people, that makes the recovery very difficult. So if we wait to try to say, well, average lifespan is, 78. Some of us are going to live longer than that. Some of us are going to live less than that. But if we're, in our late 50s or early 60s and they're talking about a knee replacement, you got to start considering that there's a good chance I might have to have this thing done again before it wears out.
They do both of them at one time.
My mother had both of them.
They will do it, because some of it kind of will depend on a person's over general health and well-being, because again, and then what kind of ability do they think you're going to have to recover? Because the rehab post-surgically still 3 to 6 months. Okay, you know, we're looking at least 90 days of rehab. So most of the time, I find that most patients after a knee replacement really don't, even if everything goes right and they are in that 50% that's better, they don't. It's not a complete deal until 18 months down the road, before all the swelling, pain, and those types of things. And then half of those people still have issues. So the other one that's kind of scary, guys, about surgery, and you know, you can't make this stuff up, comes directly from the Journal of Orthopedic Medicine, is that 4 out of every 100 will have a major infection.
That's what the doctor, I actually asked him because I have neuropathy in my leg, and I asked him, I said, well, what are the chances if I have a knee replacement, what are the chances of me getting an infection? And he told me what the chances were, and he told me possibility that I could lose my leg because of the diabetes, you know.
Well, you know, it sounds like the doctor that you were talking to was very transparent and honest with you, and we'd hope that we all are. But unfortunately, sometimes this information is not always conveyed on the front end, because I've had plenty of patients that had a knee replacement that were disappointed with the results and had told me that had I known that I had a 50% success rate, I probably would not have elected to have that surgery. Okay? So I think this is valuable information regardless of what choice you choose now or in the future. It's valuable information that we all need to know. Okay? That might change over time, but that's what the latest statistics show us. The thing that really gets me out of 4 out of 100 having a major infection, and we're talking about like staph, is that 1 in 400 will die.
Oh, wow.
So we're talking about a mortality rate right now. You're talking about a mortality rate that everybody's very fearful of the coronavirus. A simple knee replacement, and it's not simple, but you know, the mortality rate in 1 in 400 is pretty high. You know, that mortality rate I think is higher than open heart surgery. So I'm not sure why, you know, that is. I know the surgery, if you've ever been in one of those or watched it, you can probably go on YouTube and watch it now. It's pretty brutal, as we actually saw off the bone, and then we're taking the replacement and we're beating it on with a hammer. So maybe because some of that trauma, you know, and then obviously you can have potential. Well, I mean, that's the way it looks. I mean, it just that's the reality of it. That's why that's, you know, can be very sore and people have problems. No, it's not to scare you guys, but I think you need to know what the reality of what you're getting into when you do that, and what the statistics are about, you know, having a good outcome with it. Okay. Sometimes everything's been exhausted and there's just no other option. But what I try to advise people is like, listen, if you're still up and mobile and your pain level is you know 5 or 6 or below, I would have a hard time convincing myself that I'm going to go have a knee replacement. Okay. Now, if you wake up every day and you've exhausted every option known to man, a lot of the things I'm going to talk to you about tonight, and you wake up every day and you're a 10, and when you take medication you're a 9, and you stay that way every day, and you have a difficulty walking or, you know, enjoyment of life, then if you've done everything, then I could say, okay, we've exhausted all of our options. Now it's time to, unfortunately, let's move forward and send you for surgery.
I wake up a lot at night, you know, middle of the night, my legs.
And legs. So is it in your knees or just your legs in general?
This knee.
Okay, so it's specifically in the knee. Okay, all right. So hopefully what we'll learn is some things tonight that you can do that might change that. Okay, without having to have surgery. All right, so lots of scary things there, and not the greatest results.
The picture on the right, what is that?
You know, this is talking about spine surgery. Okay.
Oh, okay.
So these are the stats that typically happen with knee replacement surgery. Spine surgery is even worse. So only about 30% of low back surgeries have long-term success. So 3 out of 10 is even, that's worse. that would be, in an orthopedic realm, low back surgery would be the last surgery that I would elect somebody to have, because the success rate is just so low. Typically, patients, if they do have success, it's short term, 12 to 18 months, and then it begins to have other problems. Neck surgeries are much more successful than low back surgeries, but even like a major rotator cuff tear surgery, success rate is only 43%. So, I hear patients over 20 years of practice, I'm just going to go ahead and have surgery so I can finally get it fixed.
Yeah.
That's a misconception. Is that, okay, that's going to be a fix, because the great majority of those people, it's not a fix. Okay, it might improve, but even a 43% success rate means that that person got some better. You have 57% that won't, or worse. So you got to know your odds when you're looking at these things, and that's why we're providing the information, because it's not something you're going to find on the front of orthopedic clinics. And that's not to mean those people are bad people or bad doctors or not good doctors. And there are times where it's necessary. I just think too many times we jump to that as our first or second option, or too quick in the game, so to speak, because once it's done, the chances of us being able to help you become a lot less. I mean, we treat a lot of failed back surgeries and still have success, but after a knee replacement, and you don't have your knee anymore, what can I do? It's hard to do much, okay? So, let's talk about some of these other solutions. So, how many of you have heard of regenerative medicine or know what that is? Okay, any of you guys? Regenerative medicine? So regenerative medicine, why it's called regenerative is, think about what regenerate means. Regenerate is to make new again, to actually create or heal something, regenerate, all right? And so right now in the field of regenerative medicine is probably one of the most exciting times, particularly in the field of orthopedics, and something that we call Ortho Biologics. Now the hot term out in the regenerative medicine world, and has been for a while, is stem cell. Okay, everybody's heard stem cell before? Okay, so it is a common application that is used, or more common. I wouldn't say it's just like everybody's had it, but it's becoming more and more common for musculoskeletal disorders, and knee pain is probably number one by far. So when we're talking about orthobiologics, the FDA has got some very strict rules. We used to could call it stem cell, and then they came and said, well, can't really call it that because stem cell would need to be called stem cell. It's got to be classified as a drug, and it's got to go through a clinical study, and they want it done for every joint and all those types of things. So to jump through those hoops, you got millions and millions and millions of dollars, and typically those type of research studies are done by our universities or pharmaceutical companies. The pharmaceutical companies usually provide the funding for the universities for that. They're not in a big hurry. Pharmaceutical companies aren't in a big hurry to do those studies, because 5 of the top 10 selling medications in the United States are what? For pain and inflammation. So, we could fix you, or we could keep you taking this for the rest of your life. What's going to be more profitable? Well, more profitable is going to be keeping you treating it forever.
Yeah. Sick enough, you can.
So, it's a strategy. I mean, I've seen internal memos from pharmaceutical companies to reps that basically, here's our business strategy. And unfortunately, it's not one that I would say is very ethical. So they're not in a hurry to provide that kind of funding, and so I don't know when that will be. However, it doesn't mean we can't use it, and it's not, it doesn't work well. You just got to be careful about what you call it, okay? So there are a number of different ways to get orthobiologics. So orthobiologics just really is a broad-based term for treating orthopedic conditions with biological treatment, okay? So when we say biological treatment, the way that we apply orthobiologics is that we have healthy mothers that choose to have a C-section. And so when they choose to have a C-section, then we can have a team. You have to have a team that's called American Tissue Bank accredited, and just like if you got a organ donor. And so the mother is consented because she's going to have a C-section. We can plan this, and then the placenta and the umbilical cord are harvested from the mother, not the embryo. So some people, when we say amniotic tissue, they have been, oh, is that an embryo? No, there's a difference between amniotic and embryonic. So we're not killing babies or anything like that. That's illegal, and we wouldn't do it anyway, just from our personal standpoint and belief system. Okay, so you've got these tissues that can be harvested, the amniotic tissue and the umbilical cord tissue, and inside of that are all of these things like cytokines and growth factors, and all of these things that inside of our body, stem cells that allow our body to repair or regenerate tissues that have been injured or damaged. They do that anyway, internally. Our body does that. But in this case scenario, as we get older, this is aging, as we get older, one of the things that happens is the number of these healing cells that are available in our body begin to decline pretty rapidly, okay? So in the amniotic and umbilical cord tissue, it's all new, okay? And it's fresh, and so when we put it into a quantity, when we put it into an area that is damaged in a large quantity, now the body can take that biological treatment and begin to repair and remodel. So for instance, if somebody has great example, myself, I had an anterior cruciate ligament tear. Okay, so an anterior cruciate ligament that holds bones together. It's in your knee, and I tore it, but I didn't tear it completely. It's a partial tear. If I tore it completely, I've not been a candidate for stem cell, Ortho Biologics, PRP, any of these things, because it's not together. It's not going to heal back together. Okay, it's two separate parts. It's going to have to be surgically repaired. Now, I might be able to do the Ortho Biologic afterwards to get a better healing response, and that would be something like when we're talking about with rotator cuff surgery, where we only have a 43% success rate. Well, if you use things like PRP or Ortho Biologics, that success rate goes way up. Because why? You're using it along with the surgery to repair it, and then the healing rate improves. So like in my knee, though, it was a partial tear. So instead of having surgery, they told me I'd have to have surgery to repair it. And I said, well, doc, what does that look like for me as far as being off of it? 3 to 6 months. That's not going to work. So I did the Ortho Biologic treatment, and then I went snow skiing last March. Didn't have any trouble. My knee healed. So that partial tear, the tear healed. And so it would not have done that without the treatment, because it had actually been there for some time. So that's how these things work. So like in a knee where you have a torn meniscus or a possibly torn ligament, or in most cases a combination of those things with loss of cartilage, using this type of treatment will allow the body to actually create new cartilage or heal the areas that are damaged. Okay, so we've had great success with that. Looking at case studies over time, the patients that receive this type of treatment, 82% of them will have a 50% more reduction in pain within 60 days. Okay. Pretty good. And we don't know how long the treatment will last or how much. We've done pre and post x-rays to try to look at how much regeneration is there for cartilage, and we've had some that we saw significant changes, and we've had some where we saw moderate changes, and we've had some where we saw no changes. Obviously, the ones where we saw significant changes, in most cases, those were the ones that had the better results. But the overall results with it have been pretty good. The key is finding the good candidates, okay? So there are candidates where it's not the right fit, okay? And you're too far advanced, and if you are, then we're going to try some other things or tell you need surgery, okay? But the great majority of people, we've had people bone on bone to do this treatment and do very well. So, so that's Ortho Biologics. So one of the questions is usually, well, how much does insurance cover this? No, they do not cover that currently. There has been some early signs that insurance at some point might cover this, but right now, it's not a covered insurance service. So it is a out-of-pocket expense. What's the cost? In our office, it's $3,500 to do that, okay? Now, we typically, what we recommend is something I'm going to talk to you about this next is called platelet-rich plasma, an accelerated growth factor. What we typically try to recommend is that we do this in combination, okay? This procedure is one where we draw your blood and we take it to our lab and we extract out the plasma that's already in your blood, okay, not from a donor. And we take that plasma has your own cytokines and growth factors in it. It's not believed to have a lot of live stem cells. And so we take that solution, once we extract it out, and we get it down, and I'll tell you what it is. If you've ever got like a floor burn or you had a scab, you get the gooky stuff, not infection, but you get that yellow gooky stuff under the scab, that is plasma, okay? So what was there in that plasma? Well, that's what was healing that wound on your skin, okay? But that takes place internally. And so what we do is we take the platelet-rich plasma and we inject it into the area where there's damage. In this case, if we're talking about knees, we draw that blood, we spin it down, it takes 15, 20 minutes, we take the plasma and we put it back into the area of your complaint, the knee. Then, after that, we utilize the Ortho Biologic. We come back 1 week later, we use the donor cell Ortho Biologic. So we pair them together. Typically, this procedure is $750, okay, to do one of those. So we pair it with the Ortho Biologic at $3,500. We give you a $250 discount. So it's $4,000 to do both of those injections, okay? And we found pairing those together is what gets us the best outcome, okay? We have a device called knee decompression therapy. It's simply a table. It's right over there. And what we do is we lay you on the table and we take a harness that wraps around your ankle and foot. And then we have a motorized pulley system with a motor that actually decompresses. We block the back of the knee and it decompresses the knee joint. So if the problem is osteoarthritis and we're dealing with that, this is a treatment we found very successful. Sometimes we'll pair it with the orthobiologic and the PRP if a person's really severe, because we're trying to hit it from all angles. We charge $40 a treatment to do that treatment. Okay, typically we like to do 12 to 18 treatments. Okay. This is an injectable like the PRP. Those are injections. The orthobiologic and the PRP are injections into the knee. This is actually one called Genvis, which is something called the rooster comb. Has anybody tried that one yet? Okay, you've tried the rooster comb. Okay, so this one's called it's called hyaluronic acid. Hyaluronic acid is a protein builder in our body, a precursor to cartilage formation. Okay, so this is derived from the rooster comb, but it is FDA approved, and actually most insurances will pay for this one. Okay, what we found is that if you do this treatment in sequence with some other things, you can get really good results. Sometimes you get really good results standalone, but this treatment's not regenerative in nature. What it is a fluid therapy. The viscosity on the hyaluronic acid is very, very thick, and so when we inject it into your knee, you actually get padding or cushioning in between the knee. It just doesn't stay there. Most patients will get somewhere between 6 to 18 months of relief, and then you can repeat it. But if you've had success with it, it can be repeated every 6 months. And the benefit of that is insurance typically will pay for it. Okay? Any questions about that one? No. So a lot of times, if a person has failed this, one of the things, the questions I ask, well, how was it done? What I find is if you've got it at your primary care physician office or at an orthopedist, typically it's a one-shot deal. Okay, it works better in a series, and the research backs that up. So what we try to do is once a week for 3 to 5 weeks, depending on your response. And a lot of times we'll pair it with, like you're talking about, an orthotic, a knee brace, the decompression. So a lot of times if a person's got a financial barrier to doing some of the other treatments, we can do this treatment that their insurance will cover, and then provide some of the other, like the knee decompression is obviously a much more affordable treatment than, say, the orthobiologic, okay? not as effective, but sometimes when you do these things together, we can keep the cost down. It's very affordable for the patient, still get a desired outcome. Although this one wouldn't be necessarily regenerative in nature, so it's something at some point you're probably going to have to come back and treat again. But hey, it's still better than having to take medication, still better than maybe going to a risky surgery. Okay, another device that we use is something called pulsed electromagnetic frequency. Okay, and this is a device that was originally formulated to help our astronauts in space by creating an artificial gravity, so to speak. But what we know is, like when you have an MRI, that's called magnetic resonance imaging, and we're actually flipping the polarity in your cells so we can see different tissues. Well, this was originally designed for the NASA astronauts, but then what they found is that it would speed healing times. So, because it improves microcirculation and the energy in the mitochondria in the cell, not to get too complicated. But, so it originally started being used for like fractures that wouldn't heal. This is the type of electrotherapy treatment that they do to try to get the fracture to heal. Well, over time, we learned that this device on different frequencies has all kinds of health benefits because the effects of gravity are really part of how our body operates. So, some of the statistics in clinical studies, the device we use is called Beamer therapy, and it comes from Germany. But you can see the success rate in treatment for different types of conditions. It works very well. Typically, again, this is a treatment we usually recommend 12 to 18 treatments, and those go for $50 a treatment. Another device that we use to stimulate healing is called cold laser therapy. It's using a wavelength of light that is non-burning. It's not like a surgical laser because it operates on a different wavelength. But what cold laser does is actually brings circulation to the area, just like putting a plant in light. A plant will grow if you put it in light. Our cells are the same way, and they have certain wavelengths that stimulate different responses by the body. So we use that a lot of times in combination with our regenerative medicine. Sometimes we use it as a standalone treatment for musculoskeletal conditions. Again, this is a treatment that we charge, I think this is $40 a treatment for this.
Insurance pays for that?
Sometimes insurance will pay for cold laser, sometimes not. Individual plans vary on that one. Okay. Knee bracing. As a gentleman mentioned earlier about foot orthotics, we do that. Knee bracing is another one that can be beneficial, particularly if your knees have begun to deform. We can have what's called an increased Q angle, like if our foot rolls in, our knee will roll in like this. It's going to put unequal pressure on the inside versus the outside. We can get you in a knee brace that will help support that and actually roll that where you're getting more equal wear, and then that will take some of the pain off. Particularly successful if we're doing it with another regenerative medicine program where we're trying to, a lot of times I'll see somebody that their pain's on the inside of their knee, not the outside of their knee, or vice versa, and it's because they put more pressure on the inside than the outside. A tool like a knee brace, a customized knee brace can help, and those are typically covered by insurance as well. And then there's the orthotics that we talked about. Okay? All right, so I'm going to open the floor quickly for questions. If these, after we go through questions, if there's anything here that interests you, or you just want to have an evaluation and look at your options based on your condition, then Christy will be glad to get you an appointment for that so that we can evaluate you and determine, we'll look if you had any x-rays. If not, we'll get them. If you had an MRI, if not, and it's needed, we'll get that. But to assess your condition to see which, if any of these strategies would be applicable to you, and also something that you're interested in and would actually, can fit in your budget too. So, any questions so far?
The chicken cone, what do you call that?
Brewster cone.
Is that gelatin?
It's sometimes called a gel shot. It's not actually gelatin, but
See, I would mix that with a tuna.
the gel shot.
A pack of gelatin.
Oh, okay. No, this is actually an injection
Okay.
into your knee. Now, there's been a few that have tried to market it as an oral hyaluronic acid as an oral, along with like collagen. The results are a little mixed on that. I prefer, now I know the injection series works extremely well. We have really good success with doing the 5 series injection, and almost, you know, I'd say 7 or 8 out of 10 get really good results. It's just not something that's a permanent thing. Yeah.
How often can I take cortisone shots?
Well, cortisone shots, I don't know if we covered that on here. Let me go back and see if I've got it on my stat. That might be one, Christy, we want to add back. Because I really tried to shorten this down for you guys to not be overcomplicated. And I don't think we've got it on there. So, cortisone shots, cortisone can be, it's an anti-inflammatory. Obviously, it lowers inflammation. But the problem is that for every cortisone shot you get, within 4 months, you can have 8% bone loss. So there's a tremendous side effect to getting continual cortisone shots.
But it works.
In what way? Improves the symptom, but did it fix the problem?
Oh, no, you ain't gonna fix the problem. I got too much going on.
You can't fix the problem by what you've been told so far, but you don't know, you haven't been presented all these options either.
I've done some of them.
Some of them, yeah, but not all of them. So, I mean, I don't know without looking at your condition, but I would say that probably 9 out of 10 people that come to me tell me that they're too far gone, they can't be helped, that nothing can help them get completely better. And it's unfortunate that that's the viewpoint, because that's not accurate. Because I'll assure you, the things that we went over here, and go ask your orthopedist if he knows what pulsed electromagnetic frequency is. He's not going to know. Ask him if he knows what cold laser is. Not going to know. So if all you have is a hammer, all you see is a nail. Okay? And so what that means is, if you're a surgeon, what do you think you're going to want to do? Surgery. Okay? I'm not a surgeon. So what I'm looking to do is help people avoid that prospect, because the outcomes are not very good. So that, not to try to discredit what you're saying, I'm just saying that you realize the risk of, if you have bone loss with up to 8% in 4 months after every cortisone injection, then over time you're making your knee worse. It may feel good now, but you're making the overall condition worse over time. So I would be leery of continuing to follow that strategy. I had one lady come in here and told me she had 42 steroid injections over about an 8-year period of time. The doctor you ought to lose your license for doing that, because you completely obliterated the person's knee, and you didn't tell them that those were the side effects from it. In my mind, that's breaking the Hippocratic Oath, which is do no harm, because you certainly are doing harm when you put somebody in that, when you're doing them that frequently and that often.
And also, if you have any form of diabetes, that
Cortisone will shoot your blood sugar up.
blood sugar, my
Yeah.
blood sugar used to go up sometime 400 and 500.
Yeah, if somebody's blood sugar isn't stable, it's actually against proper medical management to give them a steroid injection, even though it happens. But the AMA does not advise that.
Yeah.
Ibuprofen, what does it exactly do? Because I had back surgery about 15 years ago, and it got to the point in my back, I was taking ibuprofen like candy. And then I was told about the kidney, and it got me worried.
Yep.
And I keep some, but like now, I might take 2 twice a week, because I'm scared of it.
Yep.
But what does that actually do?
Yeah, so it actually just inhibits inflammation. So what is inflammation? Inflammation is something that your body produces to try to heal the issue, to try to heal the problem. Okay, that's what inflammation is. So what happens when you...
The inflammation is trying to heal the problem.
Yes, right. And so what do you think you do when you try to limit that? You inhibit it. Okay, so that's what ibuprofen does. Now, it makes it feel better because it stops the inflammation, and the inflammation's painful. But your body put the inflammation there to do what? To let you know there's something wrong, and to keep you from continuing to re-injure it. Okay, that's why when you sprain an ankle, what? You don't keep walking on it, do you? No, you're supposed to rest, elevate it, ice it, so that you'd stay off of it. And so that's part of the body's defense response. So we just found that using things like cortisone injections and ibuprofen or NSAIDs and things like that can lower the inflammation and help us feel better. Okay, but the reality is it's not fixing anything, and there's some harmful side effects to it. So is it going to kill you to take a couple ibuprofen here and there? No. But if you're in the habit of taking them all the time, so it's good that you stop that. And, you know, the reality is it doesn't fix anything. It's going to help you feel better, but it's still prohibiting the area from trying to heal. And so you feel better from your perspective, from a pain standpoint, but you didn't really do anything to get the condition better overall.
What about gabapentin? What about those? Are they any kind of help to the body, or? I mean,
Yeah, so gabapentin is actually typically is given for nerve pain, and it actually affects how we perceive pain in the brain. So it can help lower your pain levels. My personal, thought of gabapentin is that I wouldn't want one of my family members to be on it unless I've exhausted every other measure, and that's for pain management, because I'd rather them be on that than an opioid. Okay, so if you've done everything else and there's nothing else to do, I think gabapentin can be, it can help with the pain. But I personally wouldn't want people to be on it long term unless it's absolutely necessary, because there's been some links to neurological disorders. There's been some links to dementia, Alzheimer's, because it affects the brain. So.
You know what? And when you said that neurological, I thought about, I've been on for years, and of course my dose has been going up.
Mm-hmm.
But of course I have this thing where I'm, starting having episodes of falling.
Mm.
And I'm wondering, is that because
Balance issues?
balance? Right.
It could be. Now, I don't know if you've got neuropathy and you've got numbness and tingling.
Mm-hmm.
A lot of it has to do with the neuropathy. But we actually have a device that we use called a Hakamed. It's from Germany as also. I didn't put it up here. And it does two things. It changes the molecular energy in the cells by something called horizontal therapy. And typically it takes us about 3 months. But in many cases of neuropathy, we're able to reverse by regenerating the nerves that way. Yeah, I'll get you before you leave, I'll get you the literature on it. There's actually double-blind studies, and the success rate is extremely high. It works very well for that. Any other questions?
Or does the turmeric do the same thing as ibuprofen?
Yeah, pretty much. Yep, it's both anti-inflammatory. Only turmeric's an herb, and it doesn't have any known side effects. So I highly recommend turmeric over, consistent use of ibuprofen.
Ready to buy it powder?
Sir,
You buy it powder?
I buy the powder. I tried the pills, but it's hard to take. Like turmeric tea.
Yeah.
And I wind up putting the turmeric tea, mixing up, and I'll put ginger and other food in the pepper.
Yeah.
And I wind up mixing it with honey and cocoa and milk.
Yeah.
I can take it like this.
Take it like
because it's so, and I'm beginning to put it in dishes.
Okay.
And with,
I typically, what I try to recommend if it's what I call a triple cocktail. So turmeric, and then glucosamine chondroitin, MSM. It has also collagen and hyaluronic acid in it. And then the arthrobin, which is the medical food. If I get all 3 people on that, I'll see that their inflammation rate all over. And then, besides those supplements, what's called a deflating diet. And I'll give you guys a copy of that. It's understanding what foods in our body will create an inflammatory response. Obviously, sugar and carbs are one of those. But there are a lot of other ones that do too. Nightshade vegetables, dairy. So you got to try to balance that out. They're called essential fatty acids. Our body, when we say essential, we have to have them, so our body won't make them. Well, that ratio should be 1 to 1, omega-6 to omega-3 fatty acids. Typical American diet is 15 to 1 omega-6 to omega-3 fatty acids. And it creates an inflammatory state all over. We really think that's part of the reason that the number of autoimmune disorders in epidemiology have increased over time significantly. It has a lot to do with our diet.
Do you think tomatoes cause inflammatory?
Oh yeah, they're acidic and they're a nightshade vegetable. Yes, they definitely. And I'm not saying you can't ever have a tomato, but if it's a staple in your diet, it can begin to cause some issues with inflammation. So we want our body to respond with inflammation normally, not in a hyperinflamed state. If you're walking around in a hyperinflamed state, every little ache and pain, every little thing that you have is going to be an ache and pain because your body is overactive. Eventually, usually leads to an autoimmune disorder called metabolic syndrome. Okay.
I got on to eating beans one time, but they got protein, they got fiber. And I got to feel terrible.
Yeah. Legumes are an inflammatory food. So
It got carbs in them.
yeah, overeating of legumes, which is beans, most beans are an inflammatory food. I'm not saying they don't have good protein and fiber and good, but if you're eating them like, oh, it's going to be like when I was growing up, we had a meat, taters, and some beans, and that was there every meal. That's the way it was. I grew up on a farm. I'm just an old farm boy. But, that's what we had every meal. Well, probably, there's nothing wrong with having some pinto beans or white beans or green beans, but if you have beans every meal,
Well, the green beans don't.
the green beans are okay. But, my dad was a crock pot, brown beans or pinto beans or white beans. So, it's all about looking at these things and how I had a conversation with some patients that are Mennonites this morning. Everything they do is organic, okay? But when I started looking at their diet, the grouping foods like, okay, so we eat a sweet potato instead of white potato, but you also had rice and bread with that meal. So now you've got 3 carbs all in that meal. So that's a problem. That's too much sugar intake, and as we take that in, our insulin level goes up. Anytime our insulin level goes up in our body to handle all that sugar, you're going to get inflammation. Okay, so
What about cabbage and broccoli and cauliflower? That's something I can eat every day and don't seem to.
that stuff has really no downsides. Green leafy vegetables and everything in that class is kind of like you can have as much as you want. Yeah. So I'll give you guys, before you leave, I'll give you guys all a packet on the Deflating Diet. It'll drive you to a website that'll give you some more information. But it'll help you out start to understand which of these foods, because really supplements are great, but they're called supplements for a reason. Our diet and what we eat is a big part of how our body's going to respond to some of these conditions that we have. Good questions. Any other questions? No? Okay. Anybody like to make an appointment?